This is the mood disorder section for behavioral science and psychiatry for Falcon Physician Reviews. So in this section, we're going to talk about the multiple mood disorders that you'll see on your exam. And there'll be major depressive disorder, dysthymic and cyclothymic disorders, bipolar I, bipolar II disorders, and other mood disorders that you'll see on the USMLE will be seasonal affective disorder, grief and bereavement, information about suicide and attempted suicide, and the Kubler-Ross stages of dying. When you have a patient that's depressed and is in your office, what are the observable behaviors that you've noticed when a person's depressed? And that is called the affect. So a person who has major depressive disorder will appear withdrawn, restricted, won't have very many variations in their mood because they're feeling depressed. So what you see is what's called the affect. But when you ask the patient, what is your mood, that is the pervasive emotion that the patient is feeling. So moods can either be sadness, elation, anger, anxiety. And mood can also be described as being either dysphoric, elevated, euthymic, expansive, or irritable. Generally, though, the mood is going to be what the patient says, and the affect is going to be what you perceive. So say a patient comes in and says he's depressed, but he's smiling and he's running around the room, well, then the affect would show that that was very inappropriate to his mood and that he was actually elevated in his affect. And so that would give you a better picture of what the patient actually looks like. So what is major depressive disorder? Major depressive disorder can be diagnosed after you've had just one episode. It has to last at least 2 weeks, and that is a very important USMLE point because they will put in the time period, and for the next few illnesses, it's very important that you know the time period for the DSM criteria. So you have to have depression for at least 2 weeks, and you have to have at least one symptom of depressed mood or anhedonia. And there must be an impairment in functioning, as well as 4 other symptoms. So there's a prevalence of depression of about 5 to 20%. Now this prevalence is very important for you to know for your exam, and it is one of the most common psychiatric illnesses known, more common in females, and has a peak age of onset around the age of 40. So how does major depression differ from normal sadness? One, it lasts much longer. Again, has to last for 2 weeks. Also, they'll have hopelessness, worthlessness, suicidal thoughts, anhedonia, which means loss of interest, somatic complaints. They won't be able to sleep or eat well. So that's how it'll differ. And it will be just much more severe than normal sadness. Normal sadness will maybe be for a couple of hours, something that you can lift yourself out of. Major depressive disorder is very pervasive, very severe, and very difficult to get yourself out of. Because of depression, there is an increased overall mortality. It is a leading cause of disability in the United States, and suicide is the 11th leading cause of death in the United States. Major depression is a risk factor for coronary heart disease. And depressed individuals need more medical resources. It might cause an impaired immune function, and it causes dysfunction in your social and occupational roles. So, what is the differential diagnosis of major depressive disorder? Again, first thing you must do is rule out any medical conditions first. Hypothyroidism is a common cause of depression or symptoms that look like depression because they will have weight gain, they will be sleeping very well, they'll be tired. Rule out Parkinson's disease. Also rule out substance abuse. Maybe someone using marijuana becomes very amotivational. Someone who is coming off of cocaine or amphetamines will become more and more depressed. So you want to make sure that there aren't any other medical or substance problems going on before you give them a diagnosis of major depressive disorder. Also, you want to make sure that they're not psychotic as a primary psychotic illness, or if they have manic phases, which then it wouldn't be major depressive disorder, it would be bipolar disorder. Again, rule out any kind of bereavement, which means sadness following the death of a significant other or someone in your family, a friend. Or you want to also rule out adjustment disorders. So for example, if you got fired from your job a week or two ago, then are you just sad because you lost your job? So that's just an adjustment disorder. So what are some risk factors for major depression? First is hereditary, environmental problems, and neurobiological reasons. They feel that in the neurobiology that there is a deficiency in serotonin, problems with dopamine and norepinephrine. Hence, that's why a lot of our medications target serotonin, dopamine, and norepinephrine, and we'll talk about those more in detail. So patients must have 5 of the 9 symptoms listed in the DSM criteria for at least 2 weeks. And one of the symptoms must be depressed mood or anhedonia. It has to impair functionality, and it cannot be caused by any medical or substance abuse. Now, sometimes you get cognitive impairments in elderly people. And what they'll do on the exam is they'll give you a vignette of a 55-year-old woman who says, I don't know for every question that you ask her. She's having memory problems, attentional problems, and they want to differentiate if this is dementia or not. And she wouldn't have known when it would have started. So those are kind of vignettes for pseudo-dementia. And the reason why they call it pseudo-dementia is because it's in an older person. They have a lot of cognitive changes like you would in dementia, but it's really depression that's causing them. So if they give you a vignette of an older person who doesn't know when it started and says, I don't know a lot, keep in mind pseudo-dementia. Treat them with an antidepressant and those symptoms will get better. Also, a lot of older individuals will have a lot of physical complaints, and you'll do tests, you won't find any other abnormalities, and then it might clue you into the diagnosis of major depressive disorder. So how do you treat major depressive disorder? First thing on your exam is that you must ask if they are suicidal or homicidal. And so on your exam it'll say, this person comes in, she's been depressed for 2 weeks, she's not eating, she's not sleeping, poor attention, concentration, anhedonia, depressed mood, and guilt. What is your next step in management? And the first thing they'll say is, start fluoxetine 10 milligrams. And then the last thing that they will write is, ask the patient if she is suicidal. So before they used to think that if you asked the patient if they were suicidal or not, that would actually give them suicidal thoughts. But it is now found that if you ask a patient if they're suicidal or not, it is actually a bit of a relief that someone would understand or even think to ask that possibly they could be having these thoughts. So asking them if they are suicidal or not is always going to be the correct question if they say, what should you do next? So make sure you assess the safety of the patient. On the exam, do not choose signing a safety contract if the patient comes in suicidal. Your best bet will be to admit the patient for hospitalization because they are a risk to themselves, because safety contracts have been proven to be easily broken. How do you treat depression? There's a combination of using medications and using psychotherapy. The combination works better than either one alone. And there are several different classes of antidepressants, such as the tricyclic antidepressants, or TCAs, the selective serotonin reuptake inhibitors, or SSRIs, and the monoamine oxidase inhibitors, or the MAOIs. And each of them have their specific side effects and profiles. Cognitive behavioral therapy has been shown through research to be very effective for major depressive episodes, especially with medications, but can be useful by itself. And electroconvulsive therapy, or ECT, is very helpful for medication refractory cases, catatonia, or for cases which you need immediate and very quick treatment. ECT can be very helpful. So there are different types of subtypes of major depressive disorder. The first kind is melancholic depression. These people will have anhedonia, diurnal variation. They'll be more depressed in the morning, less at night. Nothing will make them happy. People with some major depression will feel better if their granddaughter comes over or their child has won a contest. But people with melancholic depression, nothing will make them feel happy. They will have weight loss, guilt, Early morning awakening is also a major symptom. So the three major important facts to differentiate melancholic will be the diurnal variation, the early morning awakening, and the non-reactive mood. Then you have the atypical depression, where you'll have hypersomnia, hyperphagia, leaden paralysis, which means you feel like your limbs are very heavy, and rejection sensitivity. And atypical depression for your exam is thought to be very well treated with the MAOIs or monoamine oxidase inhibitors, and that's high yield for the exam. Then you have psychotic depression, where patients are depressed first and it gets so severe that they become psychotic, where they have delusions or hallucinations, which are generally mood congruent, but they may be mood incongruent. And in psychotic depression, you will start a antidepressant and an antipsychotic at the same time. Generally, we don't like to start too many medicines at the same time because of side effects, and we want to see which one will work first. But in this situation, you will start two medications at one time. Catatonic depression, this is where patients are mute, they're not moving, there's posturing. Treat this with benzodiazepines or electroconvulsive therapy. Postpartum depression, this starts within 1 month after delivery. And seasonal affective disorder is that this occurs in the same season for at least 2 consecutive years, and the rest of the year there is no significant depression, and this depression only primarily occurs during this season. Next we'll go into dysthymic disorders and cyclothymic disorders. We talked a little bit about dysthymic disorders with adolescents, and we noted that for them it's only 1 year in duration. But in adults, dysthymia must be for at least 2 years. And it is thought of more of a mild or chronic form of major depressive disorder. And cyclothymic disorder is also present for 2 years and thought of a more mild or chronic form of bipolar disorder. Prognosis for dysthymia is fairly good. You can use antidepressant medications. Therapy is also helpful, but this generally takes a lot longer to get better. Patients who have met criteria for dysthymia for 2 years and after that have a major depressive disorder can be considered to have double depression. So cyclothymic disorder is characterized by several periods of minor depression. So that means that they don't meet full criteria for the 2 weeks with the 5 criteria of major depression, and hypomania, meaning that they don't meet full criteria for manic episodes, which we will talk about later. And this lasts for about 2 years. And again, 2 years is the big number for both cyclothymic and dysthymic disorder that you must know for your exam. You will treat cyclothymic disorder just like you treat bipolar disorder with mood-stabilizing medications such as lithium, valproate, carbamazepine, and we will talk about these more in the next couple of sections. Dysthymic disorder has the same differential as major depressive disorder. Cyclothymic has the same differential as bipolar disorder. Bipolar I disorder. So for bipolar I disorder, you have to have at least 1 manic episode to diagnose bipolar I disorder. They don't have to have major depression. Most patients will get it, but they do not have to have it in order for you to diagnose it. And the manic episode must last for at least 1 week or be so severe that it requires hospitalization to be considered as a manic episode. The prevalence is an important point of information for you to remember for your exam. It's 0.5 to 1%. Having a first-degree relative with bipolar disorder increases your risk to 3 to 8%. It affects men and women equally. That is also important. And the mean age of onset is around 30. So what is a manic episode? You'll have a distinct period of an abnormally elevated or expansive mood lasting at least 1 week. And with that, you also have to have 3 of the following. There is an increased self-esteem, decreased need for sleep, increased talking and pressured speech, flight of ideas or racing thoughts, distractibility, and increase in goal-directed activity, and excessive involvement in pleasurable activities with high potential for painful consequences. So what are the differential diagnoses for bipolar disorder? Again, rule out medical problems. Hyperthyroidism, person on a steroid, make sure that that is. So what are the differential diagnoses for bipolar disorder? Again, rule out medical problems. Hyperthyroidism, person on a steroid, make sure that that is not an issue before you diagnose them with bipolar 1 disorder. Rule out substances. Make sure they're not using cocaine and amphetamines. That can also look like they are manic. Make sure that they're not psychotic all the time and occasionally have these up and down mood swings, because that could actually be schizoaffective disorder. Risk factors for bipolar disorder: family history of bipolar, a higher socioeconomic class, and stressful events can sometimes precede an episode. So patients with bipolar 1 actually can present first with a manic episode or a major depressive episode, but they might sometimes present with a major depressive episode and then you give them an antidepressant and it flips them into mania, and that's pretty diagnostic that they'll have a bipolar 1 disorder. So with these patients, first you have to make sure that they are not a harm to self or others. So you must see if their behaviors, because in bipolar 1s they're generally doing increased risky behaviors like spending all their money, having increased sexual activity, sometimes they'll have increased road rage. So these behaviors, these patients need to be protected. So if they are not seen for a week and they continue, then it's still bipolar. But say they're only having these behaviors for 2 days, but you stop them because you see them beforehand, but you need to hospitalize them, it is still considered a manic episode. Then you put them in the inpatient, and say they don't need inpatient, you can also do outpatient, and you treat them with mood stabilizers, such as lithium, carbamazepine, and valproate. Valproate are your initial pharmacotherapy. You can also use antipsychotics and benzodiazepines for an adjunctive therapy, and once your mood is stabilized, if they continue to be depressed, then you can add an antidepressant. But you should never add an antidepressant by itself for bipolar disorder. You should always have a mood stabilizer on board. Next we're going to talk about bipolar 2 disorder. And bipolar 2 is different from bipolar 1 in that the manic episodes are not present in bipolar 2. They have hypomanic episodes. And hypomanic is different in that it only lasts about 4 days, and it is not as severe of an episode as a manic episode in bipolar 1, but they also have to have depression in bipolar 2. So not only do they have hypomanic episodes, but they must have a major depressive episode as well. Again, hypomanic illnesses usually are not as severe and usually do not require hospitalization, but usually the major depressive episode usually requires hospitalization. You treat them with mood stabilizers and antidepressants, and similarly treated just like bipolar 1. Other mood disorders that you will see on the USMLE are your seasonal affective disorder. Again, they'll give you a very classic vignette of a lady who lives in either Europe or she lives in the northeast where it snows a lot in the winter, and she gets very depressed during the months of December, January, and February, but she's fine the rest of the year. It happens 2 years in a row. What is it? It is seasonal affective disorder. How do you treat it? Phototherapy and psychotherapy. These are the important points for your exam. Usually do ask this on the exam, so good to know. Another high-yield topic for your exam is grief and bereavement. And in the exam, they will tell you that this person has lost someone. So generally, when someone has lost someone, per the DSM, they usually return to their baseline functioning within 2 months. They might still have some sadness, they might still remember the person for up to a year, but they can return to their normal occupational, social functioning within about 2 months. And supportive psychotherapy is often used. Sometimes they might feel a little bit guilty, they might feel a little bit sad and tearful, but they won't get suicidal, they won't get as hopeless, they won't have such psychosocial impairment like you would in major depressive disorder. So that's the difference between bereavement and major depressive disorder, and the obvious stress of having lost someone. But let's say that in your vignette, it's going to be someone who had a family member die more than a year ago, and they're still not functioning well. They're not going out and talking with family members. They're staying at home all the time. They're disheveled. Or say it's a patient who lost their family member not too long ago, but they're suicidal. They wish they were dead. They feel extreme guilt and hopelessness. They're hearing voices of the person telling them to come near them. That would be pathological grief, no matter if it was within 2 months, after 2 months, but you have to look at the severity. If it is very, very severe, it then becomes major depressive disorder, irrespective of the time. Now, people with normal grief can sometimes say that they saw the person walk by them or that they felt like the person was near them, but they know that that was probably not real and they're not acting on those hallucinations. Those are pretty common. But if you have a voice telling you that you need to come die with me, something that's very bizarre, then you're thinking more along pathological grief. Now, this is also a common exam question, are the Kubler-Ross stages of adjustment to dying. And how they'll ask you these questions on the exam is they'll give you a patient vignette and ask you which stage of Kubler-Ross stages is the patient in. And you don't have to memorize the order of these stages because patients can actually start with bargaining, go to denial, and come back to depression. You don't have to be in the exact order. But the 5 stages are denial, anger, bargaining, depression, and acceptance. Frequently, this is how people progress through it. Some people may not finish to progress through all the stages, and a lot of people go back and forth through the different stages and revisit them. Also, we need to put a little bit of a note on suicide. I know we've discussed it earlier in public health, but an important USMLE point is that 10 to 15% of patients with major depressive disorder commit suicide. That number is very important. And again, firearms are the most common cause of death, and men are 4 times likely to die of suicide, and women try 3 times more. Remember to think of an old white male all by himself who has a medical illness, he has no family, and he's drinking alcohol. How do you assess suicidality? Remember, after you get these depression symptoms, the first thing you want to ask is their safety. Do they have any thoughts of wanting to hurt themselves or anyone else? Do they have any means of how they would do this? Are there any firearms in the home? Pills? Do they have a plan? Are they going to write a note? Have they ever attempted suicide before? Because again, that is an indicator that that's an increased risk of committing suicide. And do they feel very hopelessness? Hopelessness also is a good indicator of suicide. Again, always ask about suicidality every single time you see the patient, even if they're getting better. Now we'll take a break for mood disorders for behavioral science and psychiatry for Falcon.